Tune in weekly and listen to the Collateral Damage podcast, where Michael Wilson and Maureen Cavanaugh host a variety of special guests to discuss topics and available services that will help you learn about the impact that substance use has on our lives, our families, and on our communities nationwide. Episodes and listening information can be found at www.cdpodcast.com. You can also search for Collateral Damage Podcast on your favorite listening platforms or watch previous and future episodes on YouTube. Don't forget to subscribe and share. We'd like to thank Sunrise Detox for sponsoring this episode of Collateral Damage. Welcome, everybody, to another episode of Collateral Damage. My name is Mike Wilson.
And I am Maureen Cavanaugh,
my amazing co-host. And today we have a special guest, Dr. Mark Tyndall, who is the professor of medicine at the University of British Columbia and also the founder of My Safe Project, which Dr. Tyndall, if I'm not mistaken, that is a vending machine that you created to dispense hydromorphone pills. Is that right?
Yeah, that's what I've been working on the last few months.
Okay, and this is, where is this taking place now?
So in Vancouver, many people have heard of the infamous downtown east side. So for decades, Vancouver's had quite an active drug scene, really compressed into sort of a ghetto of people living in poverty and using a lot of drugs.
Okay. And what was it that inspired you to go down this road? I mean, you obviously saw a need, right? You saw a need that needed to be filled, that people did not have access, or that you wanted to find a way to give people access to this. What was it that inspired that?
Well, I've worked in the community for over 20 years. So my background is an infectious disease doctor, and I started out treating people for HIV, and then got involved in HIV prevention area, including a lot of harm reduction. So I was involved in early needle exchanges and supervised injection sites. And the overdose crisis really hit Vancouver hard in about 2016. So I've been focusing on that over the last few years, obviously bringing in the work I've done around harm reduction, and we've tried to ramp up or scale up the work that we were doing. But clearly, when the street drug market was poisoned by fentanyl, it wasn't enough. So I've been working on the idea of that people deserve access to a safer supply of opioids.
Mm-hmm. So this is definitely to try to curb the overdose crisis. I mean, along with things like, the Insight Safe Injection Sites, these are all part of a bigger picture harm reduction model to basically keep people alive, right? I mean, you can't help them if they're not alive. So at the very least, keeping people, giving them this safe access to a substance that's not tainted.
And it doesn't take long to, I spend a lot of my time around supervised injection sites and other harm reduction programs, and it doesn't take long to realize that they're very limited. I mean, to just over and over just watch people overdose and give them the naloxone and then walk back out the door and buy more is, it becomes a bit of a vicious circle, and a lot of people don't come back again. So, I mean, it's just, to me, it's just a ethical and practical way to deal with a street drug supply that is now very dangerous for people.
You know what, if we could just back up a little bit, because we're now in the United States I think we're starting to get to the point where we're going to be accepting the safe injection sites. So I'm just curious what you saw in the beginning when that was first introduced in Vancouver, in British Columbia, and what kind of an impact that had.
Well, that's a great question. When I follow what's happening in the U.S., especially the focus is now around Philadelphia, trying to open up their place. And it's just the same thing over and over. It's deja vu from probably, 15 years ago in Vancouver, when really it started as a grassroots effort, and the community started it. There was a couple of unsanctioned supervised injection sites that were going on. As a physician down there, I dropped by some evenings and provided some, very superficial medical care, and just basically directed some people they should go to the hospital, sort of thing, and looked after some wounds and things. So these were going on. much before Insight happened, which was the sanctioned supervised injection site. And that finally opened in 2003. So that's 17 years ago, basically.
Wow.
And so the same community, concerns were voiced at that time. This would just be a disaster, or just drive all these people into the community to use these services. And what are we doing, allowing people to use drugs anyways? And they should all be in treatment and care. And all these same arguments were there 17 years ago. But I was involved in the evaluation of this. We did some fairly rigorous scientific evaluations, and all the fears that people had never materialized. And at that point in time too, it just seemed to be a practical thing. If you take somebody who's injecting in the rain and running away from police is a pretty bad situation for everybody. And allowing people to come inside where you could actually talk to them and they could get a clean needle, this made all the sense in the world. But the history of supervised injection sites in British Columbia are quite sad also. So Insight was the only place, within 6 months, it was already at capacity, and we needed more. And that didn't happen until 2016, when the government allowed them to open, and based on the overdose crisis. And now in the province of British Columbia, there's about 30 of these functioning in different communities.
It's interesting. You said about the fears that never really manifested themselves, like these things everybody was so afraid of. And here we have a lot of sober living down here, and there's call them NIMBYs, not in my backyard. People who they gather, and I assume that you probably had similar folks when the injection sites were being discussed and planned, was that they have all of these fears that you're going to bring these people to our community, that you're going to create these problems that don't currently exist. And they do exist, you just don't see them because we don't have a safe place for them to do them, or they're not getting help. It's happening in the shadows. And I remember working with a local official who was just fairly ignorant to the whole process, and we were explaining our plans for sober living, and he said, well, what happens if they go AWOL? And I was like, what? I don't know what that means. What do you mean? He's like, well, what happens if they escape and they're wandering the streets? And I was like, what happens if a voluntary participant decides to leave? The same thing that would happen if we weren't there, I was like, but because we're there, they have an opportunity to get well, and, you'd be supporting that. And it was just always, to me, it was baffling that some of those fears, I understand them, but they're so unfounded, it's just, and I assume that's probably what you've run into with the injection sites, and we're running into it now. And
we have, strong scientific data. There's been probably 50 peer-reviewed papers around Insight. We followed a large cohort of over 800 people who are using the site, and documented all kinds of positive outcomes from the use of Insight. Yeah. And still, I could find myself at a community forum, as an expert in this and having the science behind me, and some guy who found a needle in his backyard is debating me about supervised injection sites and harm reduction, and the crowd would be split in half.
Really? Wow.
It's really based on ideology, like that. Basically, the narrative is that people shouldn't use drugs, and that anything you do to try to connect with people who use drugs we shouldn't even bother. They should just stop using drugs. And so, and I've argued that, the idea that we take somebody who's, entrenched in their drug use and expect the first thing they should do is abstinence, it makes absolutely no sense. And then they're wondering why that's not working for them. I mean, the obvious thing is to work people back. So you take what they're doing now, which is, injecting dangerous drugs in dangerous places, and give them some other alternative to that, and then you can maybe work up a ladder if that's their trajectory for their addiction. But this idea that our first approach should be locking people in a room and telling them to stop using drugs is it's just illogical.
Yeah, it's unrealistic.
Are there other services associated with Insight? So beyond this, the availability of clean needles and And so,
Yeah, it's evolved, and I think we're in BC, we have a natural experiment now because these other supervised sites have been allowed to create some of their own rules, and they've developed in response to what the community needs. And Insight now is looked upon as too medicalized. So there's doctors there, there's nurses there, and for a lot of people that's fine, but just the idea that people can go and use drugs in a safe way without feeling any pressure that somebody's going to be asking them, can you please get on methadone and stop using these drugs? I mean, and the whole medicalization of it, and that brings in different rules, and people now can get banned for their behavior and things. And across the road, I'm working with one that's a much lower barrier place. With no services really. There's people there who are trained with naloxone to respond to overdoses, and that site is way more popular. So there's much more of a.
Really?
So people have kind of voted with their feet as far as where they feel most comfortable, and for most people on any given day, they appreciate the opportunity to go inside and maybe talk to somebody if they want to, but. Even for Insight, there's there's an expectation that people. Oh, sorry about that. You can.
We can cut that out.
Rid of that. I guess.
Yeah, don't worry about it.
I can edit that for you. Don't worry.
Sorry about that. So the people vote with their feet. They like lower barrier things and without any strings attached. So, and even at Insight, most people, if just being around there and observing, most people come in with their head down, they sign in, they go to their desk, they do their thing, and they get out. And that's what the first step for most people is. So, your question about, I think as we pile on more services that we think are doing, are useful for people and they deserve those services, we have to be careful that we don't overshoot and over medicalize it, because then it becomes a barrier for people attending.
Interesting. And to what end with the machines as well? Are those being placed in locations where they can get access to more services, or do you think they're going to be looking for that same model of just let me get in and get out?
Well, there's several components to this idea of putting the drugs in a machine. One is just the whole concept of what a safe supply should be. And again, we've had some experience in Vancouver. We have a clinic called Crosstown, which gives heroin injections and hydromorphone injections to about 150 people. And that's been going on for almost a decade. Wow. It was an extension of two clinical trials that were conducted in Vancouver, one called Naomi, which was a heroin trial, and one called Salome, which also used hydromorphone injections. And just for ethical reasons, people who are doing so well on these programs, they've been allowed to continue, mostly with the original people that were in it. And they're just now expanding a little bit. But so we knew that a safe supply was very useful for people, obviously. So the idea of using a machine was just, to me, a scalable model that you could do this at a pretty cost-effective way. But the technology itself, there's a lot of, I'm just learning myself. We've had it up and running for about 2.5 months. There's just 15 people using it right now. So every day we learn new things. But I spend a lot of time there. I talk to people, and consistently the most important thing people say about it is the autonomy. They can come in when they want, get it. It takes about 10 seconds. They get their drugs and they leave. And there's no expectation that they use their drugs at that time. So people can have some flexibility of when they actually use them. So they can't use on site. They take them out the door. And it's fascinating. When I first introduce people to them, one of the questions is always, well, now what? I say, well, just take the drugs. They're safe, and you to go home and use them. And
no strings attached, right?
No strings attached. I want you to use them. And the idea that people can get on a much more a regulated, they get up in the morning feeling drug sick, and they, instead of going to the alley, or actually most people's day is doing something to get money, which often is a little bit risky for them, and often involves criminal activity. And just why would we ask people to do that? It's insane, really. Here's the drugs, and then you can get your life a little bit more organized, and people really appreciate it. And in a very short time, I would say half the people have been it's transformative, and
Sure.
the other half are kind of catching up, and they're doing better. But there's people that in 2 months have picked up part-time jobs, and they all are not doing the same amount of crime. They're certainly not using the street drugs that they were. I mean, it's not magic. I test people's urine, and most of them still have fentanyl in their urine. I mean, it's still that, they haven't totally eliminated their street involvement or street drugs, but it's way down. And to me, it's just at this point in time when it's so dangerous to buy these drugs and use them, we have to offer people an alternative rather than abstinence.
Mm-hmm. You know what? I feel like there's a down here. You were talking about how the site that is over medicalized, right? There's access to all these services that that's the goal. I think the goal is to make sure that the folks who are accessing those services have access to additional services. Because if they're not talking about it, then they don't have enough information to make that decision when the time is right. And down here, we're definitely trying to mix the two with all of our clinics, via Suboxone, methadone, and stuff like that. That they're coming in for Suboxone it's like every 2 weeks to get their prescription. For methadone it's every morning, and they have to meet with counselors and case managers, so they're kind of locked into it. They don't have a choice. And I find it interesting that when presented with the choice, as you said, they voted with their feet, and they were just like, I'm not really interested in talking about it. And the majority just want to just let me do my thing. I'll do it in a safe way, but just let me do my thing. And it's just interesting. I don't.
We're really uncomfortable with that, right? And that the medical community and everybody's very uncomfortable with this idea that people shouldn't be expected to link to services.
Right.
They will, though. So people, if people can get themselves a bit more stable, then they have the opportunity to think about that and make those, initiate those connections themselves. Certainly, they should be available. I've prescribed more than enough methadone in my life. I'm not, anti methadone or Suboxone. But the idea is that basically the way we've constructed our methadone programs, at least in Canada, they're part of an abstinence-based kind of mentality. We're telling people, we don't want you using these drugs. Use this drug. Come every day, line up at a pharmacy, get your drugs, and we'll do urine tests. And we're kind of ensnaring people in something that they may not have signed up for. And so I'm all, when people are ready to do that, clearly there's thousands of people who have benefited greatly from these programs. But my experience is the people who do well on them have gone through a lot of things before they do well on them. And we can't just abandon people who are not ready to sign up for that and just say, well, come back when you're ready. And, 4 or 5 years ago, in my clinical work, that would be likely they come back in 6 months and try again. And now they don't come back in 6 months because they're dead. And so letting somebody, people not, adhering to your methadone program and falling off, and then we just sit there and wait for them maybe to come back. And, in British Columbia, there's 5,000 people in the last 3 years who haven't come back, and they won't come back. So I just find now we have to offer people other alternatives than just saying, stick to my program or else we can't really do much for you. And, at the end of the day, we're telling people just don't use drugs.
It doesn't work.
I remember that campaign. That didn't work. Yeah.
No, and I mean, there are some people that are just not going to recover in the way we want them to recover. And I say we, I mean like the general public, our idea of recovery, abstinence, or whatever that idea is. Some people will not get there, but they'll still be alive.
Still be alive. I mean, I've been at this community. There's people that I came to Vancouver in 1999 to start working in a clinic there, and there's people today who are I still see, like they're still, and two or three of them are in my program right now, and they're, I don't know what their trajectory in life is, how, it looks like a tough life they've led, and with their drug use, but they're still alive, and then doing
Yeah.
things. And I mean, that's that's their life and their life trajectory. And I think as a society, we've created such a horrible situation for people by our drug policies. And I've argued that it has very little to do with the drugs. Like people can use heroin for 20 years and be fine. But they're not fine because they've been arrested and beat up, and they've spent all their money on extortionary drug prices. And so
And they're not really using heroin. They're using all kinds of synthetics that they don't
now
even know
using
that
the
they're using.
nickname
Yeah.
heroin. Yeah.
Yep.
So it's a horrible life, but it's because our drug policies have created a horrible life for people. And and the only way, I've also argued that people will stop or reduce their drug use when they find something better to do than drugs. And for many people, that getting drugs and getting high is about all they got going for them right now. And we need to find something else to replace that for people, or they need to find something else themselves to replace that.
Isn't that that's the rat park experiment?
Sure. Yeah.
Where the original rat park was just, or the original rat experiment was just one rat in a cage with a bottle of cocaine water and regular water. And once it identified the cocaine water, it just did that until it died. There was nothing else to do. And so this was an experiment from back in the 70s. And then they redid the experiment and came up with Rat Park, which is where they created this rat utopia. And they took rats who had been isolated using that cocaine water and put them in a larger park with more rats and more social activities and things to do. And they said a large majority of them just stopped doing the cocaine water. There were other things to do. And so they just engaged other things. Rats don't want to be cocaine addicts.
Well, the 15 people that I've enrolled in the program, I asked them what they want out of the program, and everyone says to reduce or stop their drug use. Like, and so
Right.
it's that, people understand that what they're doing and the cycle that they're in at the current time is not sustainable, not enjoyable. Like, it's really a grind for people. And so they'd like nothing more than to get out of that. But what we offer them often has so many strings attached. The system is so stigmatizing too. Even, we've worked really hard at, in hospitals and clinics to really try and reduce the stigma, because people walk through and they're identified right away as drug seekers and drug use. Who needs that kind of humiliation, basically?
Right.
And even our methadone programs are really based on humiliation. We take people who are trying to stop or reduce their drug use and tell them to line up with all these other people doing the same thing every morning. I mean, it's humiliating and stigmatizing. And so we've created, what we think is helpful situations for people, that we're kind of doing them a favor. But we've, these programs have been designed to meet doctors in the medical system where we're at, not people where they're at. And
Interesting.
I think that's true. How are those 15 people chosen to participate in the study?
Yeah, well, it's early days. There was quite a lot of concerns or skepticism about the technology as it works. So it's a biometric machine. So it's about an 800-pound square box, more like an ATM, that is filled with individual prescriptions. And people put their hand up to the machine. It reads the vein pattern in their palm and identifies them through biometrics. And they can get their pills dispensed in about 10 seconds and leave. So, but there was a lot of concern that, people wouldn't like that, or they wouldn't use biometrics, or the machine would malfunction. So I handpicked 5 people just to demonstrate that it could work, the technology. And, I'm open to learning too. It's a brand new idea and a brand new thing. So I was very interested in how people use the machine and how consistent they use it, if they had trouble with biometrics, all those things, that it was a learning process. I've got up to 15. I would say the last 10 have just been compassionate access. So people come to me and say, I have to have this, I've just overdosed. And so, there's if I put a sign up tomorrow that, anybody, please sign up, there'd be lineups around the block for sure. But I've been very careful in not allowing that many people in until I kind of prove the concept. And so, as I say, the last 10 people have really all been compassionate. Like, I just feel that some of them I know, and they come to me, begging me to be on the program because they're so scared of buying fentanyl. So we've slowly increased the numbers.
Any thoughts in dispensing Suboxone or methadone like this?
Yeah, I think that, the technology itself, I think, has a lot of applications, and I picked the hardest one. But obviously, methadone and Suboxone should be put on these machines. People don't want to go to a pharmacy every day and don't want all those rules, and they want the convenience of getting it when they want and things. So I think they have a lot of potential. I've also been involved in, through my career, getting people HIV medications, Hep C medications, and the biggest issue with this is adherence and making sure people are taking their pills. And again, this kind of machine could really help a lot of people get through their treatment.
Yeah, they would have to come and take everything all at the same time, I would imagine.
Yeah, and I have real time. I have a dashboard. I have an app. I know exactly every pill that's coming out of that machine in real time. I know who got. I can tell you who got their last pill. Somebody got one 5 minutes ago, kind of thing. So it's very regulated in some ways. The other beauty of it, I can program the machine to give out as much and at what time I want. So everybody starts off having to come 4 times a day to get 1 dose at a time. But if things are going well, we can program the machine to get 2 doses at a time, twice a day. And then, that's where I've got to for some people now, but no reason people couldn't come every couple of days and get their doses.
Right. That'll be an interesting way to eliminate the cattle line, if you will, of the methadone clinics and the overcrowded doctor's offices for Suboxone, and or mixing. Down here we get the doctor's offices where it's just a regular family physician might be giving out the medication, and then they're feeling they've got that person in the corner that feels all guilty and shameful, like everybody knows what they're doing, when they could be just going directly to the source,
or that they can't get there every day. Which is
and these machines could operate 24/7, so people have
in a variety of locations, right?
In a variety of locations. It could be all. Right now, it's a prescription model, so every pill packet that goes in there is assigned to a certain individual. So there's 48 lanes in the machine, so that a machine could take on 48 clients. But there's no reason that we couldn't put a bunch of machines and people could qualify to be in all the machines, and we could still regulate it. So people may still only be able to access the machine 4 times a day, but they could do it at different locations, and we could still keep track. There's a real problem with people being stuck to their pharmacy in Canada. So basically you can't go anywhere. So if you wanted to visit a friend somewhere, you'd be stuck for the weekend. So this kind of technology would allow people to access their medications in other locations.
We hope that you're enjoying this episode of Collateral Damage. Now please take a moment to recognize our sponsors.
I hit rock bottom so hard that I bounced twice. My disease had me battered, beaten, and broken. I used to live and lived to use. Nothing mattered to me. And it wasn't until I entered a detox that I had, trained clinical professionals that were able to help combat my disease of addiction.
At Sunrise, we understand the courage it takes to look in the mirror and go, I just can't do this anymore. Give Sunrise a call. If you're even thinking about it, your recovery has already started.
We'd like to thank Sunrise Detox for sponsoring this episode of Collateral Damage. And now back to our episode. Now you have the universal healthcare up there, right? So this is not individually paid for through an individual's insurance, right? This is all public health money.
Well, I don't have, to be honest, I don't have a big swell of support from the Ministry of Health, and so cost is an issue. governments are, risk averse by definition. So this is a scary thing for ministries of health and health authorities and things. So I've I kind of left my official job and just did this on my own, just to prove the concept. About a year ago, I decided that the only way to even get one machine on the ground was to just do it myself. I think, and I had 100 conversations with governing bodies and colleges and all this, and so they weren't going to be flexible in allowing this to happen. But so basically the narrative of this machine is I'm writing a legal prescription for somebody, dilaudid pills or hydromorphone. They go to a regular pharmacy, the pharmacy packages them up and dispenses them just like normal. And then after they leave the pharmacy, there's really no regulation about what people do with their medications. So the people in this program have consented or elected to have their pills stored in this machine. So
I gotcha.
These are their medications. It's not me as a doctor filling up this machine with hydromorphone and handing it out to people. These are their medications, and they're putting them in a safe locked box. And who could think that's a bad idea? People, right, especially when they're marginally housed, do you want to put a week of hydromorphone in a shopping cart? And so to me, this is just a very secure way for people to keep their drugs safe. And gotcha. And I'm not really challenging any of the current regulations as far as prescribing. So right. It's so right now the people who are on social assistance have a medication program that it's subsidized, so it's free to them. If I got 1,000 people on this program and brought in a whole bunch of other machines, we'd probably have to talk to the government about how we're going to, if they're willing to actually subsidize these medications. But a dilaudid pill in Canada is 35 cents. So a full dose for people is about $6 a day. So it's not a huge expense, especially when you consider the alternative, which is hospitalizations, ambulance calls, crime. Like there's a ton of expenses for doing nothing. So in the whole scheme of things, this is a really cost-effective thing to do.
Yeah,
I like that. I mean, I was just wondering because I was thinking about how that translates down here. Like if it was ever to pick up speed and come down here, I would find it hard to believe that the state would pick up the tab or that the federal government would pick up the tab. I think it would be, or the privatized insurance companies. I think somebody would want to make money off of it. Because that's what we do down here.
Well, you could, one model, which I wouldn't necessarily support, is that people could purchase these drugs. So the machine could just be, we'd still regulate it, but instead of paying $15 for a flap of unknown powder in the back alley, people could pay $3 and get some dilaudid pills. So, and right. I think a lot of people would elect to do that. So,
or even, those boxes being, like a pharmacy, an unstaffed pharmacy, with certain available medications where prescriptions could be filled, stored and housed without any interaction, with the patient bringing the medication and saying, I'm willing to store it here. Just it's filled, it's stored. I can come back and get it at certain doses. I would imagine that would be a useful tool.
Interesting.
Yeah.
Well, the people, when you get down to it, the difference between hydromorphone, giving out hydromorphone, and you should understand that most people are grinding these up and cooking them and injecting them. So the pills are still injected for the most part, which has happened, which happens commonly. But the idea that we would support methadone and Suboxone because that takes away people's cravings and controls their withdrawal symptoms. Basically, that's what hydromorphone does too, only it allows people to get high. And I think there's a real concern that we would do nothing to allow people to get any kind of pleasure from the drugs. But to me, hydromorphone is just the same as methadone, except people can get high. And so it's to me, if you're willing to subsidize methadone, then why wouldn't you subsidize hydromorphone for people? Because I think as a society, we have a lot of trouble with that. Like
Yeah.
we really love Suboxone because it gives people no enjoyment. It just strictly treats their withdrawal symptoms.
Only
And
if you take it as prescribed, because
yeah,
I've used it. I'm a person in recovery. I can tell you, I've used it and I've gotten high on both
yeah,
Suboxone and methadone.
okay,
And it's
yeah,
just about
but it's tougher.
yeah,
Like
it's all about how you manage your doses. I mean, take
yeah,
as prescribed. The goal is for you to not feel anything good.
right.
But being the addict that I was, I always made my own goals. So,
Yeah, no, I'm sure, but yeah, methadone's a more difficult high than hydromorphone, I think. So
agreed.
most
Yeah.
people would admit that. So, but we are really concerned that anybody, and then at the end of the day, why people are taking these drugs in the first place is to get high and self-medicate. And why would we think not giving them that possibility be a good thing? Like that's why people, we're not really addressing why people are using the drugs in the first place. And so
Right.
and but I agree, I've seen, as you'd be more of an expert than I am, Michael, but as far as people's trajectory, I mean, people come to different points in their lives and they want different things and need different things. And so I think we just have to open up a spectrum of opportunities for people. And I think a lot of people on a hydromorphone program would end up on a methadone program at some point, but I can't predict when that would happen for them. And I don't think by giving them hydromorphone really influences how that happens. I think I think people feel that this is enabling. If you're giving people the drugs that they want, why would they want to change? But it's just the opposite. You give them some stability, and then they can think about why they might want to change. So I just think it's counterintuitive to most people. But this is not enabling. This is really allowing people some stability, and then they can make other decisions that that maybe we think is more beneficial. But I don't think it's enabling at all. To take some woman who's selling sex in the back alleys and giving her the drugs so she doesn't have to sell sex is a huge, that's huge for somebody.
Absolutely.
Yeah.
I mean, I think that, there's that fear that it's enabling this, and I'm sure that you've heard this before. There's this idea that if you make it this easy, people that don't have an addiction will want to, it will make it more appealing for them to try it and all this. People say stuff like that. But I think if you ask any mother, and I've gone through this with my daughter, and I thank God that she's still with me. But if you ask any mother who's lost a child, whether they would prefer this or they would prefer that, their child to be using street drugs and pass away, I don't think there's not much of a debate there anymore. So
no, I agree. Yeah, a lot of really sorry. I will throw my phone out, but it's now somehow attached to my computer. So I put it off my phone, but everybody's like,
the power of connected technology.
Yeah, exactly.
I love it. Can't escape.
So I'm curious, what's the route in Vancouver if you say, okay, I'm going to go on the machine, I'm going to get a daily dose or whatever, but I really would like to get off of everything. What happens in Vancouver if that's what they want?
Well, there's a lot, again, I'm working in a very concentrated area. There's tons of services, clinics, methadone. So there's everybody on this program has failed multiple times in what we're offering them. So if somebody came to me tomorrow and said, look, I'd really like to get on a methadone program, they could get it the same day.
It's available there. Like I'm just wondering, what if somebody did get that clarity, right? They're not, running around trying to find ways to buy drugs and who to buy drugs from, dealing with all this dangerous stuff. And they realize that, what, I want my life before this back.
Yeah.
And they don't want to be on anything. Is there a way to do that easily in Vancouver?
Easily. I mean, it's again, the downtown east side maybe it doesn't represent the whole province, but I think on the whole, especially in the last 4 years, there's been a real emphasis on getting more opportunities for people to get on substitution therapy, Suboxone and methadone. So I don't know the last statistics, but somewhere around 20,000 people in the province of 4 million are on methadone. So it's a big big program. There's a lot of people on methadone. There's a lot of physicians prescribing, a lot of pharmacies giving it out. So there is no real barriers to that. But the rules, so anybody, that would be great. If I think.
What about a complete detox and then treatment? Do you have that available there? I'm just curious as to what's available in Vancouver.
Yeah, like everywhere, it's could be better, but there's a lot of opportunities for short-term detox. But in this, we're really pushing back on these ideas that it's a good idea for you to go for 2 weeks detox. I mean, the chance of you coming out of there not using drugs is so low, and once you're detoxed, your chance of overdosing is so high. So some of the biggest risks are people coming out of these short-term detox and they overdose, and people coming out of the prison system, obviously. So it's a huge problem. So people, if they want to pursue a detox and a recovery program, there's lots of opportunities for people to do that. But with the fentanyls that's out on the street now, for a lot of people, that's hugely precarious unless they've really got a long-term plan. But people who are just pushed into, why don't you just get into this bed for 7 days and we'll detox you and give you some methadone or whatever we want to do with you. That I'm really concerned that a lot of these programs aren't looking far enough ahead and dumping people back on the street who have basically lost their tolerance, and they take the smallest amount of fentanyl and they go down. And it's a real precarious situation now for people to pursue short-term detox for opioids.
What about Vivitrol? Is there much use of Vivitrol there?
No, I personally don't think it's a good idea, but no, there's really not much. I don't know anybody on it.
Really?
Wow.
Yeah.
That's interesting because it's being used more down here, I guess.
Yeah, but I guess if whatever works. There's probably people you get on the show who said that's the best thing that ever happened to them, and they're doing great. And
Right.
we need to. I'm not dissing any.
No, it's just interesting to know what goes on in another place, what's going on there. Even as far as what about, housing? So somebody's on methadone or they're on Suboxone or they're coming in for their medication. And is there availability of housing? Do you have, what kind of services? That's kind of what I meant before when I said services. Like if somebody needs food and they need a roof over their head and they need access to employment, are there services like that available?
Lots of services. Is there enough? Not nearly.
No, there's never going to be enough.
Fall through the cracks. We have, there's been, Vancouver is notorious for a housing price. It's very difficult for anybody to live here now. So it's been a real problem, and a lot of people who are using drugs end up on the short end of housing and services and stuff. But there's ample, people aren't starving. There's tons of food programs and things, but it's still very sad. I mean, we don't, the welfare system that we have in Canada is just so inadequate. So, we give people $700 a month or something, and they expect them to survive somehow. So, I mean, it's very, it's terrible. But it's not that nobody's thought about it, and there's modular housing that's gone up, and there's things, but there's I believe housing is so critical to people to stabilize them. But there's a natural experiment that happened just outside of Vancouver where there was a notorious street, and there's about 400 people that were living in tents along the street. And there's a clinic right there that I worked in. I went once a month to do some HIV work there, and they built modular housing, 3 big modular housing units. They went up like in 6 months. People were selected, and about probably 3/4 of the people living in tents on that street got a room with their own bathroom. There was food services on site, and it was amazing. They were really an important intervention. But if you go there at 9 o'clock in the morning, the place empties out, because people are still using drugs.
Right.
It didn't, and they're still on the street. And now it's even harder because the government has decided, well, we've given people housing, so we have zero tolerance for people loitering and all this. So people now are chased to the, even more dangerous places. So we have to still, that the housing won't solve everything for people.
Right.
It's really critical. But again, we need, to take care of the addiction and what,
Right. So they're addressing the symptom, but not the cause. Yeah.
Yeah. So we still take traumatized people and give them a house. It's great. But they need other things to
Right.
make it work. So,
Absolutely.
yeah. So, I mean, I think the downtown east side has been such a focus for the city of Vancouver. So we have this, beautiful modern city, and then we have 5 square blocks of human misery all at one place. And for people who have toured through there, I've given 100 tours of the downtown east side, and people are amazed. You cross one street and all of a sudden you appear to be in a totally different world. And there's been a lot of money poured into that, and housing and supports and outreach. And so there's been a real effort to do that, but it's just fallen short, and we still have a lot of people living in tents.
With all the availability of all this harm reduction, do you see any decrease in the new cases of AIDS, of HIV?
Oh yeah, there's hardly any HIV spread right now.
I'm seeing a lot of it here, new cases here.
Yeah, needles are everywhere. The people, as far as access to them, I mean, it's interesting as far as this enabling argument. So, 20 years ago, giving people needles would be like, you're just enabling people to use drugs would be the biggest argument. And maybe that still exists in some place in the United States. But now if people come for needles, we ask them, can you take more and give them to your friends, basically.
That's awesome.
Every clinic, so there's really no reason people would need to reuse or share a needle in Vancouver. And most people are fairly educated about that they would never think to do that. And there's people walk around with boxes of needles. So it's so transmission of infectious diseases are much lower. Hep C, it's so easy to transmit hepatitis C, but there's still new infections and mostly reinfections because we've treated quite a few people. But HIV, at one point in the 90s, there were 35% of the people living in that community were HIV positive. Now, 25 years later, most of those people have passed away. But there's still a lot of people on antiretroviral treatment in the community. And the spread is, there's very few new infections happening.
That's good to hear. So we're going to have to wrap up, and I really appreciate you coming on. But I'm just wondering if there was one thing that you could change, if there was that you could look at overall that you think would make the biggest impact, what would that be?
Well, people think of this as the overdose epidemic has really pulled the curtain back on exactly, how little we're doing for people. And so the risk of overdosing today in British Columbia is about the same as it was 4 years ago. The chance of dying might be less because we have supervised injection sites and a lot of naloxone on the street. But the number of people overdosing hasn't changed that much. The risk hasn't changed that much. And so my progression in thinking about harm reduction and addiction is our only ethical response now is decriminalization of drug use and giving people access to a safer supply of drugs. And this is now radical, this is a radical idea and crazy idea, but if people look back on what we're doing now is crazy. Like, we take people that are, traumatized in the worst shape of anybody in our community, and we decided to criminalize them and just punish them more and more. It's like, and just re-traumatizing people all over again, and then expecting them to somehow recover. And so I'm really, we really need to totally change the way we approach this. It's more than just a health. It's not good enough just to say, well, it's a health issue, because we haven't really changed our policies. It's still illegal, and we still have a heavy-handed criminal justice system. We fill our jails up with people who are using drugs and drive them to the periphery, and now they're dying. It's like, I just find it unethical, and we really need to totally rethink what we're doing to people who are using drugs. And just to meet them where they're at means give them access to the drugs they're using right now in a safe way, and then they can, work their way up some kind of trajectory or ladder. But just closing the door on any possibility that they, other than abstinence for the most part, is getting us nowhere. And we're just, losing literally hundreds of thousands of people that do not need to die and do not need to be treated this way.
I love it. Where there's breath, there's hope, right?
Yep. Well,
Excellent.
Great.
thank you so much.
Okay, my pleasure. Thanks for asking me.
Thank you.
Bye-bye.
Bye-bye.
Thank
See ya.